Good morning, everybody from Baden-Baden, Germany. Christoph Fien, I'm a rheumatologist in Baden-Baden, Germany. I want to talk about the benefits of subcutaneous versus oral methotrexate in rheumatoid arthritis treatment. These are my disclosures. Firstly, methotrexate still in the year 2020 is the anchor drug and the drug of first choice in early rheumatoid arthritis. There was a recent survey of 212 rheumatologists worldwide, mainly Europeans, and it was found that 71% followed international guidelines, and in 81% they start with methotrexate, mostly oral, in early RA. In the graph on the left side you see that DMARD monotherapy with methotrexate, unless there are contraindications, is the drug of choice in the majority of all rheumatologists. And this reflects the recent EULA recommendations from 2017, where methotrexate should be part of the first treatment strategy, and as well the ACR guidelines of 2015. Where the panel voted that methotrexate should be the preferred initial DMARD for most patients with established RA. So, firstly, we should go deeper in the pharmacology of methotrexate. Methotrexate is regulated by cellular uptake and polyglutamation after it is given. Methotrexate acts on folate-dependent enzymes, and there are two ways how it acts. Firstly, on the right side there is antiproliferation and immunosuppression, and on the left side there is induction of adenosine, and adenosine is mainly an anti-inflammatory substance. So this is probably the secret why methotrexate is more effective on inflammation, on arthritis, in comparison to other immune modulatory drugs. But firstly, when you give methotrexate, it has to be uptaken into the cells, and there are two ways. The left side, the folate receptor beta, and on the right side, the reduced folate carrier. Methotrexate is taken up like folate is taken up into the cells, and the folate receptor beta is mainly on monocytes macrophages, while a reduced folate receptor carrier is on all cells in the body. And so on this way folate is taken up, and when it's in the cell it's activated by polyglutamation. So to explain this, polyglutamation is the coupling of glutamates to the methotrexate molecule. You see it on the right side. There are glutamate residues coupled, and up to 5 glutamate groups are coupled to the molecule of methotrexate with the enzyme polyglutamate synthetase. And this results in intracellular persistence of methotrexate and a higher affinity for folate-dependent enzymes such as ICAR transformylase, the enzyme which is responsible for the adenosine accumulation in the cells. So when this happens, polyglutamates accumulate intercellular, and they reach a steady state after about 15 weeks. On this graph you see how the different amounts of glutamated methotrexate is accumulated. The left side up 1, then 2 residues, 3, down on the bottom left side 4, then in the middle 5, and on the right the total polyglutamated methotrexate. And you see that it's not an immediate effect, it goes a while, and there is with all polyglutamates a steady state at about 10 to 12 weeks. And this reflects very much as well the clinical course of MTX treatment. So you don't have an immediate effect like with prednisone. It takes a while, but when the activated polyglutamate methotrexate is accumulated in the cells, then you have a stable effect. So, and if you discontinue methotrexate on the right side here, again, it's not the effect does not stop immediately. It takes a while. So, for example, if you make a break because of infection, then you don't lose the effect after some days. It takes a while, but so after 6 to 8 weeks, the amount of polyglutamated activated methoxate goes down, and then the arthritis comes back. So the pharmacology of methoxate reflects very much as well the clinical signs of methoxate treatment. And the polyglutamates are well shown that they are associated with the effect of methoxate, and they are measured in erythrocytes. And when you measure this, it's associated with a lower disease activity in patients with rheumatoid arthritis. This is a prospective longitudinal cohort study in RA, and they found a cut-off value of polyglutamated methoxate. So for the two glutamate residues coupled to methoxate, there was a cutoff value of 22 nanomole per liter on the left side. For total polyglutamated methoxate, 74 nanomole per liter. And on the right side, you see that there is a good discrimination between patients with moderate or good response to methoxate versus non-response. And with the two glutamate residues, you have a sensitivity and specificity of 65 or 82%, and a very good positive and negative predictive value. And more or less the same, it's with total MTX polyglutamate on the right side, where again you have a cutoff value where you have a good prediction of response to methoxate. So polyglutamates are associated with a good clinical response, and so it's a task to have polyglutamated methoxate by your treatment. And the rate of highly polyglutamated intracellular MTX depends from different parameters. On the left side, you see it's dependent from the dose. So you have as higher the dose, as higher the polyglutamated methoxate. The optimum is over 20 milligrams per week methoxate. On the right side, you see again as well, but that the type of application is as well important. You see that subcutaneous methoxate on the right side gives you higher polyglutamated methoxate values than oral. So this is a sign that subcutaneous methoxate probably should be more effective. There are other factors influencing methoxate polyglutamation. This is age and induced renal clearance, which increases polyglutamation. You should as well look for toxicity in this case then, while smoking and NSAID use decreases polyglutamation. So why is this with the oral methoxate? And when you look into the literature, you find that the mechanisms of oral uptake of methoxate are not discovered a long time ago. It was just 2006 when there was a Cell paper which identified the intestinal folate transporter and the molecular basis of this uptake. And the receptor is called proton-coupled folate transporter, which is the main transporter for folate and methoxate resorption in the proximal small bowel. And so this is the fourth folate transporter which is known. The others are the reduced folate carrier, which is on every cell but has only a minor role in intestinal resorption. The beta folate receptors, which are very important in arthritis because they take up methoxate in the monocytic cells and the macrophages in inflammation, and the alpha folate receptors which are important for cancer treatment because this receptor is found on epithelial cells. And these receptors are this intestinal folate transporter was described in a family with a hereditary folate malabsorption. They didn't have proton-coupled folate transporter. They had only the way of the reduced folate carrier for uptake of folate, and all the members of the family had a very low folate concentration in the blood. So this intestinal folate MTX transporter is influenced by many factors, which makes it very difficult to foresee the uptake. Firstly, the increasing pH does decrease the resorption of folate and methoxate. So there's an optimum with a pH of 5.5, but if it goes up, for example by proton pump inhibitors, the MTX resorption is reduced. Secondly, a high folate supply does decrease the expression of this transporter. And thirdly, chronic alcohol consumption reduces the function of this transporter. So many factors influencing the resorption, and in the individual patients you should exclude all those points to rely on resorption of MTX when you give it orally. And additionally, there is a problem with dose increase in oral MTX. You have a plateau at 50 milligram oral MTX when you measure the area under the curve. This is a graph from a pharmacological study where oral methoxate is compared to subcutaneous methoxate with the autoinjector, and you see there is a plateau at 50 milligrams methoxate per week. When you increase to 20 or 25, you don't have a higher area under the curve with oral MTX, and this is different to subcutaneous MTX, where you have a linear factor to the area under the curve when you increase the dose. Okay, so how is it clinical in my patients? There was a milestone clinical trial of Jürgen Braun in 2008, where a randomized, placebo-controlled trial compared subcutaneous versus oral MTX. There was a randomization to oral 15 milligrams per week methoxate versus 15 milligrams subcutaneous methoxate, and when after 16 weeks the primary outcome of ACR20 was not reached, you could switch from oral to subcutaneous methoxate, or when it happened in the subcutaneous group, you switched from 15 to 20 milligram subcutaneous. So you had the possibility for dose escalation. And in this clinical trial, the primary outcome was met with significantly higher ACR20 values in the subcutaneous group, as well higher values in the for the ACR70 criteria. So the outcome was met, and in the groups where it was not met, we had in 23% of the patients we found an ACR20 at the end of the study, when the dose was increased from 15 to 20 milligrams, and in 30% of the patients it was found when the oral given methoxate 15 milligrams per week was switched to subcutaneously given methoxate. There was no clear difference in the adverse events between the both groups. The total numbers of adverse events and serious adverse events were not different in the subcutaneous and oral MTX groups in this clinical trial. However, more adverse events leading to withdrawal in subcutaneously methoxate were found. However, altogether the safety was the same in the oral and the subcutaneous group. This result of a prospective randomized trial was as well reproduced in the cohort study, in a prospective cohort study in 2016 by Hazelwood et al. And they had different doses of methotrexate and oral because it was not a clinical prospective trial. But the switch from subcutaneous methotrexate to oral was less often than from oral to subcutaneous, where you had 49% and 77%. After adjusting, subcutaneous methotrexate had a lower rate of treatment failures. On the left side, you see the graph of the DAS at 28. You see that there was less DAS at 28 in the group with subcutaneous methotrexate at the end of the clinical trial, of the cohort study, in comparison to oral methotrexate. This was only a small difference, but there was a large difference between adherence to treatment, and you had highly more patients who were on the treatment after 12 months in the subcutaneous methotrexate group in comparison to oral methotrexate. So adherence to treatment is very important for the treatment. There was a recent survey, a questionnaire to patients with rheumatoid arthritis on MTX in the US, and it was found that 50% of the patients report non-adherence, and you see that mainly communication problems are responsible for this. The patient told that they forgot that they have to take the medicament, then they thought that they don't have to take it when they feel well, or they had problems with concerns about long-term safety. And this fact is the reason why we chose in the German guideline for treatment of RA a 6 weeks point when we see the patient the next time after the start of the treatment, because we want to speak with them and we want to exclude the communication problems. Finally, there was a good correlation of all those clinical trials and cohort studies to real-life findings in the US. In more than 30,000 patients with oral MTX, there was a follow-up made by analysis of prescribing practices in the US, and it was found that about 56% of the patients had to change treatment after a while, and 87% switched to a biological drug, and those were 48% of all oral MTX patients, and this happened after 170 days in the mean. So after half a year, they had to switch to a biological drug. Only 13% of the patients, of all patients, received subcutaneous methotrexate, and from those, only 28% of the patients switched or added biological drugs. So, and this was a much lower rate, and this happened after a mean of 289 days, so much later. And this is what brought the authors to the conclusion that the delay or prevention of the escalation of methotrexate treatment to a biological drug is possible by subcutaneous methotrexate, and that there is an underuse in methotrexate in the treatment of rheumatoid arthritis in the US. So, what is the summary? Methotrexate is the drug of first choice and the anchor drug in all international guidelines for the treatment of RA, even in the year 2020. And subcutaneous methotrexate has favorable pharmacological properties, is prior to all MTX in clinical effectiveness, which has been showed in a well-performed prospective clinical trial, and it improves drug adherence in RA patients. In a prospective cohort study this was shown, and it seems to be capable to prevent or delay the switch or adding of a biological DMARD in real-life RA treatment, as has been shown by the analysis of data from the US. Thank you very much.